Hello, everybody. My name is Meinolf Suttorp from Dresden in Germany. I'm a pediatric hemato-oncologist at the Technical University, the Department of Pediatrics. And today I'm going to talk about a side effect of TKI treatment, which is specific for children and adolescents, disturbances in growth and endocrine function. The survival probability by TKI treatment has dramatically increased during the last 20 years, from a cure and survival rate of 50% in the 1990s. We are now have reached a 95 to 100% probability of survival. But this success comes with a lot of side effects. When imatinib was developed, it was learned rapidly that it is not a specific inhibitor of BCR-ABL only, but also inhibits DDR1 and platelet-derived growth factor receptors and the stem cell factor receptor. As you can see from this dendrogram of more than 500 tyrosine kinases who are active in the human body. So nilotinib was developed to be a more specific inhibitor and a stronger inhibitor. And you see by this size of the arrow that it primarily inhibits BCR-ABL1, but also, of course, the other tyrosine kinases listed here. And dasatinib, on the contrary, was developed to be a broader, less specific inhibitor, and this also has a strong inhibitory action on the SRC kinase. So in sharp contrast to other pediatric malignancies, CML anti-neoplastic treatment is performed for an indefinite period of time. And we must regard now CML in its true sense as a chronic leukemia, which may require a lifelong treatment in at least some children and adults. So from an optimistic viewpoint, one may say this is the best possible world. There will be new drugs in the future to cure CML, but the pessimistic approach would mean that this lifelong treatment is necessary in the majority, and we will observe a lot of side effects. When we go back to those first years, imatinib was licensed in most countries in Europe and in the world in the year 2003. And when attending congresses in the year 2005, 2006, everybody was talking about a wonderful drug, exciting targeted treatment with good responses. However, do we have experience with growth? The kids grow poorly, don't they? And there was the first reports in the years 2008 by Mariani from Italy, and 1 year later from Kimoto in Japan, and from my group with just one child. And here is the growth chart, the height at start of therapy in a 5-year-old girl in chronic phase. There was a completely molecular response after 3.5 years of treatment, but the longitudinal growth dropped from the 74th percentile down to the 7th percentile. And another very illustrative and impressive case of identical twins was published by Hobanich, who could show that the sibling, the twin with the CML treated after 4 years, was half a head size smaller than her identical twin sister. So in the next years, then, larger cohorts were described by Bansal in India, Shima in Japan, 20 and 48 patients by my collaborator, Frédéric Millot from France, 81 patients. We published our own observation cohort in 2014 as ASH abstract. And from India again was another report on 36 patients. And the largest cohort is described by Cheng, unfortunately on Japanese, with English abstract only, with 238 patients. And I'm going to run through these reports in the next minutes to show you more details. So Bansal analyzed 20 patients, and he reported the height standard deviation score. That means compared to the references for India, he had a rather small cohort, which at start of treatment was already 1.2 standard deviations below the average. And then during a period of 7 years of treatment, there was a decline in the standard score down to 2.5. So these children lost within a 6-year period 1.5 standard deviations. Shima selected another approach to present their data. They calculated for the individual patients the delta standard deviation score. That means what is lost during treatment. So starting at 0, after 1 year, there was a loss of half a standard deviation score, and this further dropped to almost 1.8 during a 6 to 7 year period. And when they separated their data into prepubertal and pubertal children, this effect was observed only in prepubertal children, but not at pubertal age, where there was no deviation, no delta of the standard deviation. Frédéric Millot from France showed in 81 patients that there was hardly any effect. He started with a rather tall cohort of plus 0.5 height standard deviation score. And during a shorter period of 2.5 years, these children lost around 0.7 standard deviations. And when he did a statistical analysis on prepubertal and postpubertal changes, there was no significant difference, and also there was no significant difference between boys and girls and prepubertal and postpubertal boys and girls. So there was an effect, but this was rather a little growth impairment only. In our own cohort, we could demonstrate that after 3 months already, you see the effect in the decline of the standard deviation, presented here as delta SDS, and this continues over the period, but after more than 3 years, the numbers here become rather small. And I also want to focus your interest on the broad range of the standard deviation score. The gray shaded area here is a normal range from +2 to -2. And you see that individual patients are severely affected or are not affected at all. While when talking about the median, there clearly is a decrease. And when we separate this data into prepubertal and into pubertal and postpubertal cohorts, we could show that postpubertal, there is hardly any growth, so it can't be impaired. In pubertal children, 10 to 14 years old, the effect is less strong, but children at the age 1 to 9 years are affected mostly from this side effect of TKI treatment. Bodu from India also analyzed the size of the height of the mid-parental of the parents and also of the siblings. And he selected another way to present the data. Here's the height Z-score of the pre-imatinib therapy, and this was measured in 24 children of a 36 children's cohort only. And you see the median here is in the range of -1 SD. That is, again, a rather small cohort to start. And when the treatment was performed for, if I remember correctly, 3 years, the standard deviation dropped to a median -2, so a loss of 1 Z-score. And here is in blue color now the patient height Z-score after the TKI treatment or during TKI treatment when the analysis was performed, and compared to the mid-parental height, these children are smaller, and there's a big difference to their sibling height, which is in the median range of -0.2, while the median here is -1.8. Although this cohort initially was a little bit small, it is a clear effect that they do not reach their mid-parental height, and the siblings grow regular. The largest cohort from India demonstrates in 238 patients, always has been said before, the mean height when these patients completed a questionnaire was significantly lower than at the time of starting the treatment. So it dropped from 0.4 to from plus 0.4 to -0 roughly. And the multivariate analysis showed that younger age at the start of treatment and the longer duration of imatinib therapy are significantly associated with this severe growth impairment. What do we know about the second generation TKIs? Well, there are only very small cohorts analyzed. There's a study performed by Leah Gore and published in 2018. And there, in 84 children, there were 2 children affected by growth impairment at any grade, but it was not a severe grade. And they also say that this is a preliminary statement. They will continue to collect data on growth, and that will be reported once mature. And Nobuko Hiai has analyzed the data for nilotinib from the phase 2 trial she conducted. And there is a cohort here shown in blue of pre-treated patients with imatinib and dasatinib who were switched to nilotinib. And this starts at height standard deviation score of -0.5. And during the course of 4 years, drops to -1.5 median. This is not weeks or months. This is time window cycle number, but 48 cycles are roughly equivalent to 48 months. And for the cohort of the newly diagnosed patients who were treated upfront with nilotinib, there was 0 standard deviation at the start of treatment, and then there was a slow decline ending up by again -0.5 standard deviation loss in growth. So it seems to be, at least for nilotinib, more or less the same as for imatinib. But all this is based on small case numbers. So what should you do when treating a patient? You have to monitor the growth, and that means that you have to document the body height, the weight, the pubertal stage, and then you calculate the height percentiles, and do not forget to document the parental height so that you can calculate the mid-parental height, and you calculate the prospective terminal height, what the patient can expect from what he or she has inherited. And if possible, also documents the siblings' height to assure that there is a normal growth and development in the family. And most importantly, determine at start of treatment the patient's bone age. I'm going to show you why in a couple of minutes. And during treatment, this of course should continue. You document how the child is growing and keeping weight or putting on weight, the pubertal stage, 3 monthly if appropriate for age, and you calculate the deviation from the standard deviation height score compared to the time point of diagnosis, and at yearly intervals perform an X-ray of the left hand to determine the bone age. And most importantly, talk to the patient and talk to the parents that compared to the general population, most of the patients are within this gray shaded area. There are only rather few patients who are really problematic cases because they are below the -2 standard deviation. But of course, within a family, when the younger sibling is overtaking in body height the patient, this may cause severe problems, but not within the general population. It's interesting to go back to one of the first cases reported from Kimoto in 2009. The girl they described was at diagnosis -7 standard deviation. So she was a little bit small, and she was treated by a pretty high dose, by an adult 400 milligram dose, and she grew very, very poorly, almost stopped growing here, cutting the percentiles, and by the age of 9.5 years, she was at the -2 standard deviation. So this is pathologically small, and her height when she was 11 years old was -2.7. But interestingly, at this age of 11 years, her bone age was 7 years. So she was delayed in her bone age. She had low bone mineral density by that time. The bone formation markers and the bone resorption markers are low, but then the treatment was stopped because this high dose had worked excellently. She was in deep molecular remission, and then she went to stem cell transplantation. And 2 months after the TKI was stopped, she started with, well, how should we call it? A catch-up growth or a pubertal growth spurt. The insert here shows for the two sexes what you all know, that before puberty starts, there is this dramatic increase in growth velocity earlier in girls than in boys. And so this might have contributed that she grew in parallel to the percentiles, but then there was some adding up from -2.7 to -2.5, but you cannot expect that she will enter the normal range, because shortly after this growth spurt happens, the pubertal growth spurt, then the epiphyseal lines close and growth stops. But it's interesting that you can learn all the key problems from one of the first cases reported at that time. So we turn now to bone metabolism a little bit, through bone remodeling. In all men and women, there's a constantly remodeling of the bone, meaning that the bone is reshaped and that the osteoclast resorbs the bone, for example, to see that there is calcium homeostasis. And this starts as so-called microcrackles caused by physical activity, and then the osteoclasts will mature and will start with the resorption of bone, but almost immediately mononuclear cells develop into mature osteoblasts, who then will start to fill in this gap by bone formation. And this ongoing remodeling process dissolves the whole skeleton of an adult within a 7-year period and rebuilds it, of course. In a child, that means that when the bones become bigger, there must be resorption at the inner part of the bone marrow cavity, and there must be bone added at the outer part of the corticalis to assure that the bone comes thicker. But also it must grow into the length. And what I stress here is that the angel here has to be remodeled. That means there must be some bone material added at the inside when this angel becomes a longer bone, and there must be osteoclastic activity at the outside to take material away. And in a rat model, we could nicely show that also big changes at the growth plate are induced by TKI treatment. Here is the epiphyseal line at a rat at prepubertal, pubertal, and postpubertal age. And when you expose this animal for a prolonged period of several weeks while they are growing, this covers a 10-week period from prepubertal to postpubertal. You see in the controls that the epiphyseal line develops and get calcified, but under high doses of imatinib, you see that the hyaline cartilage is disarranged, and that are kind of tissue damage within these epiphyseal lines in rats, of course, but you can assume that it's similar happens in children. In vitro, you can also show how the osteoblasts are inhibited. In the controls over a 25 period, mineral calcified tissue is formed as shown in black, and by adding imatinib to the cell culture medium, there is a decrease in the formation of the calcified tissue. And in a seminal article by Kate Van Dyke, I think from Adelaide, it was shown that imatinib inhibits the osteoblasts, the differentiation of the osteoblast by inhibiting platelet-derived growth factor receptor, and also the activity of the osteoblasts. And in the same way, imatinib inhibits c-KIT and CFMS, So the differentiation of the osteoclasts is impaired and their action is also impaired. That means that the activity of osteoblasts and osteoclasts is reduced, like both parts of this scale are blocked. And this happens at an inhibitory concentration in the range where BCR-ABL is inhibited. So as a result, there's impaired bone formation and impaired bone resorption. If you compare different ages, in an older, outgrown adult, osteoporosis is the main problem because the osteoclasts are more active. And if these osteoclasts are blocked, an older adult may profit from TKI treatment. And there are adult data showing that hypocalcemia and hypoparathyroidism are more pronounced in younger adults. And FITTER showed that increased trabecular density and reduced number of lacunae can be found in adults. And Johnson showed that the bone mineral density is increased. But in children, there is ongoing bone growth and there's an increase in bone mass in the net comparison. So the osteoblastic activity is more important. And the peak bone mass should be reached in a 25-year-old young adult as a reserve for bone loss in old age. And that may be a concern in children treated with TKI. We also measured the hormone levels of parathyroid hormone, and these were increased, showing over the period of 3 years, just above the upper normal range, that there is ongoing bone resorption. And another endocrine impact is that the hypothalamic hypophyseal axis is impaired, and there's low growth hormone secretion. Growth hormone is difficult to measure, but in a cohort of 21 patients, all but one patient had insulin-like growth factor levels, which is a surrogate marker for growth hormone in the lower normal range, and IGF binding protein 3, which also correlates strongly with the growth hormone, was low. The same was shown by Narayana from India in a cohort. And by multiple reports, we do not have any doubt that imatinib disrupts the growth hormone IGF-1 axis, but we do not know exactly at which part in this cascade this happens. There is a report that 12 of 17 adult CML patients had severe growth hormone deficiency, and this might in part explain why so many patients feel tired and complain about fatigue. There's a single case in a girl showing growth hormone deficiency. The study by Narayanan I mentioned already. There was a 7 out of 18 pediatric patients a pathological growth hormone stimulation test, and in 16 out of 18 patients low IGF-1 and low IGF binding protein. And our cohort showed in 20 out of 21 patients that there was a low IGF-1 and low IGF binding protein levels. And an interesting in vitro investigation on tumor tissue on somatotropina showed that there was an inhibition of growth hormone signaling. So it might be that even here in the growth hormone release axis, there is disturbance, but somehow down this line to the IGF-1 formation. then there is an impaired vitamin D production. We measured in a cohort during the winter time, that are the dark squares, and in the summertime, these are the stars, the vitamin D levels, and they mostly were below the gray shaded normal range. And from my group, Lysan Melik could nicely demonstrate that keratinocytes kept in vitro synthesized vitamin D during time when irradiated with ultraviolet light. But if imatinib or nilotinib was added to the culture medium, there was a much lesser production, and nilotinib acting stronger than imatinib. So the reason for this might be that the cytochrome P24A1 enzymes are modulated and inhibited, and if there is a high enzyme expression, a vitamin D deficiency might result as a consequence as this downstream cascade of calcitriol formation is blocked. So summing up this part, I believe that the disturbed bone remodeling results from the inhibition of osteoblasts and osteoclasts, that as another mechanism, the growth hormone axis is disturbed and there is a decreased formation or secretion of growth hormone, and there are, as third factor, low vitamin D levels. Do not forget to look at the tooth in very young children. There's one analysis from the international registry where we looked at patients younger than 3 years. This is only a small proportion of 4%, 22 out of 522. But in 3 of these 22 children, there was a tooth developmental delay. They were very young at diagnosis of CML in chronic phase and received different TKI treatments, and then 3 to 12 years later, these tooth defects became more pronounced and were described. There might be also a problem with bone healing if there are fractures. There was a first report of a 5-year-old male with ALL who during maintenance treatment received imatinib, and when he had a tibial fracture, there was excessive callus formation and a non-union of the tibia. In the cohort in Germany, we observed 7 fractures in 6 patients, but the important message is that these circumstances all were regular circumstances observed in teenagers doing sport like basketball or trampoline or skiing, jogging, indoor handball and street ball. And there was no complication. There were complications in 2 patients, but this was complicated metatarsal fracture and right trochanter major because of osteonecrosis, but all the others had regular healing. So this may show in this small cohort that the TKI does not affect the healing after a bone fracture. And looking last but not least to some other endocrine side effects, there has been description of hypothyroidism or hyperthyroidism induced by all TKIs. This is rare in teenage and adolescent young adult patients and should be treated only if clinically relevant. Nilotinib is known to induce hyperglycemia, but this is observed less frequent with other TKIs. And on the contrary, Also, hypoglycemia has been observed with an improvement of type 2 diabetes. 3 cohorts were investigated by Comos Samano, and this cohort with normal fasting plasma glucose levels had no changes during the first 6 months of treatment. If impaired fasting plasma glucose was observed, this was corrected during treatment. And in type 2 diabetes mellitus, the plasma glucose level decreased dramatically so that the treatment could be reduced. Gonadal function is impaired by all TKIs in animal models. There may be delay of puberty in individual cases and also potentially decreased fertility. But there's a big question mark here. We need a lot more data on this, and it is questionable whether prophylactic cryoconservation of sperm and ovary tissue should be recommended. But of course, you do need this when you go to stem cell transplantation. And if you're more interested, please read this article by Samis, an excellent overview on the endocrine side effects of TKIs. This brings me to the end of my talk. I hope I have not more confused you than transferred any interesting knowledge, and thank you for your attention.